Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My goal here is to find that person that is, maybe 1 in 1,000. And in their field, they've really chosen to excel and succeed and do great things. So my guest today, in the spirit of that, is George Mazariegos. He's a director of Pediatric Transplantation at Children's Hospital of Pittsburgh. He's also a professor at University of Pittsburgh in the Department of Surgery. So George, thanks for coming. How are you doing today?
Richard, thank you very much. I'm doing well, and I'm glad to be chatting with you this day. Thank you.
Yeah, I didn't know that, I guess, unfortunately, pediatric transplantation is probably a big need. Why did you decide to focus in that area? And then I wanted to get into some of the procedures that I guess kids need in terms of transplantation. So some background on you first, like what attracted you to this area?
Thank you. It's been a bit of a journey for sure to really find the niche and the calling that is what I sense now in pediatric transplantation. And what is really exciting to note, and what perhaps is not as well known to the listeners, is that pediatric transplantation really was the beginning of the transplant field that was pioneered by Thomas Starzl in the 60s for liver in particular. All of the early clinical successes were in children, and many of the lessons that the field has learned and many of the challenges that the field is continuing to learn really center around trying to help children overcome the challenges to a successful transplant. And they were really the beginners, the pioneers, and continue to be the ones who push the field forward. The need is not as numerically significant as the adult transplantation need from the number perspective, but qualitatively and for impact on a lifetime, it really is an incredible opportunity and need even now.
So what kind of conditions necessitate transplants into children, and children of what age range? We
look at the age category really as a broad one, and the National Global Health World Health Organization definition of a child is really a person under the age of 18, and we see that through the spectrum of disease, there are really a significant spectrum of diseases that occur in children beginning at birth and all the way through the adolescent period. And in many of those cases, there are groups of diseases that really affect children at all that age spectrum in different ways. The majority of the children that we care for are young, and that would be defined as either newborn up through infancy and early childhood. For the purposes of the discussion, really the child from birth to about age 5 or 6. And there's really an amazing heterogeneity in the kinds of diseases and challenges that these children face. About half of them are genetic in origin, and about half of them are not clearly genetically based, but present in the early childhood period. And of course, we're talking about transplantation broadly. We can think about transplantation challenges for children who have heart or lung disease, children who have liver disease, intestinal disease, and kidney disease. I primarily focus in my daily life on children with liver and intestinal disease, although here at the Children's Hospital of Pittsburgh, we care for children in organ failure of all those types, and different team members from our team here work in the care of all of those children. In liver and intestine disease, it's really split about 50% between the genetic and congenital diseases and other types of liver or intestinal disease.
If you do a transplant on a child that's young enough, do they still have to be immunosuppressed forever? Or, perhaps their immune system is underdeveloped to the point where they can assimilate the new organ or transplant and live normally? Is that possible?
Yeah, that's a great question, Richard. We, in general, the indication and timing of transplant is driven by the necessity. And so when we have children who present with life-threatening organ failure at an early age, perhaps with neonatal liver failure, for example, then that child requires transplant at that time. In other cases, the disease progression itself doesn't really develop until a later age. We've learned from different transplant processes over the years that the immune system is more pliable at an early age in life. And so, for example, heart transplants, which can be a challenging transplant to do later in life due to chronic type rejection that occurs in the organ, can actually be accepted when the child is a baby, and can even be done across blood types, which isn't possible later in life. The challenge is that you don't want to do that transplant in infancy if you don't need to, of course. But we have learned some immunologic lessons, particularly in heart and in liver transplant, about low need for immunosuppression when the immune system can be modeled. Unfortunately, it's not something that can be tailored yet into clinical practice, but it may benefit those who do require transplant at that very early time period. Most children, and by most we're talking about 95% of children, require lifelong immunosuppression, and this is an area that is a significant part of my research and the research of those that are in the community to try to understand why the 5% can reach the tolerant state and be living a healthy life with a healthy organ with no immunosuppression.
That do need immunosuppression, what does that look like throughout their lifespan? Do they need less and less of it or more of it over time? What does that seem?
One of the things that drew me to transplantation when I was a general surgery resident was that meeting patients who had undergone transplantation was really transformative and allowed me to see that the picture I had of a very chronically ill patient on lifelong immunosuppressive therapy, despite having navigated a successful transplant, but not having achieved a normal quality of life was really what I had in mind, and was not the case. It was really amazing to see that when patients, and particularly children, were restored to a healthy recovery after transplant, that it was often impossible to tell them apart from non-transplant patients. And we've really made some significant progress with immunosuppression over the years, and it was really transforming to see patients who really returned to normal life. And having said that, to answer your question, particularly in children, there are greater challenges with the immunosuppression that is required to help patients maintain their graft than really fearing about recurrent disease or other acquired diseases that adults have to worry or contend with. It is rare for children to have recurrent disease of the liver that would come back after transplant. In many cases, the transplant is curative, and in only rare diseases, in only rare conditions, is the disease possible to recur. That's not the case as much in adults who have to deal with adult viral-related complications or complications of recurrent malignancy and tumor. And so for the child, the real challenge is to navigate a whole lifetime of immunosuppression with the minimal amount needed to keep the liver healthy, and yet avoid any long-term damage to the liver through immune-mediated problems or rejection.
The nuance of the immunosuppression, why is it better today versus years ago? What does it do that works better?
Some of the things that have happened in immunosuppression have been to really understand that although the drugs haven't dramatically changed in the last 20 years. Most patients are on what's called a calcineurin inhibitor, and this is the main drug that the majority of transplant patients are on. What we have done, particularly for children, is we've been able to monitor the side effects of immunosuppression and titrate the dosing before complications became more significant. And the most significant complication that was affecting children 20 years ago were viral complications. This manifested in many ways, most classically in a syndrome that was due to Epstein-Barr virus infection, EBV, what commonly is known to folks as infectious mononucleosis, but can, in a transplant patient, present as a significant lymphoproliferative disease, basically a cancer that could progress because of B-cell proliferation that gets unchecked because of the T-cell inhibition of the calcineurin inhibitor. It's been the ability to monitor levels of virus in our bloodstream, basically, that allows us to measure those levels in children, even when they're completely asymptomatic, and lower the immunosuppression levels before that type of virus can become unchecked. And then this currently in the era, of course, that we're facing now with the virus infection, it really underscores the key role that managing viruses for our transplant patients is really paramount in our transplant community, and it has been a big focus for the last decades.
Someone is immunosuppressed and goes about their life. They're given, drugs to keep them that way, but are those drugs, are you saying that there's a possibility of tailoring the amount of drugs and the frequency that they're getting them based on external conditions, based on biomarkers and things like that?
That's right. That's exactly correct. We can titrate based on the levels of these secondary markers or effects of over-immunosuppression, like virus markers, viral markers such as the ones that I mentioned for EBV or other viruses like CMV. We can also titrate the effect of the drug on the kidney system because some of these drugs have deleterious potential effects on the renal system or the non-organ that's transplanted. And if for a liver recipient, we check on the kidney. We make sure they're not hypertensive, and we adjust those. And this allows long-term benefits to be really sustained over a period of time, where the patient won't suffer from a life-threatening viral infection, as was more common 20 years ago, and will have healthy liver function, healthy kidney function. The other biomarker that we use to balance out the infection risk is really looking at the health of the transplanted organ, the liver and the kidney. And we look at that through biopsy changes right now. We're hoping to develop more subtle or less invasive biomarkers to look at the transplanted organ, but right now liver biopsy or renal biopsy, heart biopsy, et cetera, are a gold standard for really assessing that there's no destructive immune process that's happening in the organ, and can allow us to further lower immunosuppression to the lowest level possible. So we look for infections, we look for those complications, and we look at the organ itself. And when we don't see destructive changes, then we can lower immunosuppression further. And this was work that was really led by Thomas Starzl, the father of transplantation, if you will, here in Pittsburgh in the late 80s and early 90s, who worked on these types of patients, particularly for children who face the longest potential burden of immunosuppression, transplanted for hopefully a lifetime.
What about when a child goes through puberty? For women as they cycle, is there any modulation of it? If a woman wants to get pregnant and have a child, is that possible while being immunosuppressed? Those scenarios.
Yeah. In terms of what happens over the span of a lifetime, there's some fascinating changes. I think one of the questions that you asked earlier was what happens as children grow, and do they need more or less? And every patient is different, and there are some patients who do need to maintain a certain level of immunosuppressant as they grow, and this is based on some of those markers that we've talked about already on the interview. If they've developed rejection, then they may need to maintain a level and may need to increase the level of drug that they're taking over time. For others, though, as they grow, they develop no changes in their liver graft and almost auto-wean themselves by measure of taking the same amount of medicine that they took when they were children, now that they're adults. On the other hand, for patients who are on immunosuppressant medications, changes like adolescence can be a challenging time point, mostly from the adherence point of view, and abrupt changes in the medicine adherence can lead to significant rejection or problems in the transplanted organ. For women of childbearing age, though, there's great news, and that is that many successful pregnancies have been reported in transplanted women with normal childbirth, and this has been really recorded across all of the transplanted organ recipients. There's a pregnancy registry that's been developed to really track and report on the successful delivery of children to transplanted patients, and this has been well reported now. So one of the greatest treats, of course, in my life has been to see patients who have transplanted as children then grow up and have a family, and to be able to really be a part of that was fantastic. There are some practical things that physician teams who are caring for patients who do become pregnant follow, and some of this relates to some specific medicines that have to be stopped during pregnancy. The main medicine that I mentioned, the tacrolimus or the calcineurin inhibitor, however, can be taken throughout pregnancy and does not have any effects on the developing baby. The other ancillary medicines may need to be adjusted and are reviewed at the time of the pregnancy and perinatal care to ensure that none of those medicines are on board during pregnancy.
Well, I guess pregnancy itself demonstrates like a segregation of immunity to keep the baby, being able to grow and not being rejected anyway. So it's good that doesn't interfere.
Yes, that's exactly right.
So what when someone's had a transplant, what's the protocol? Do they just take a couple of medications every day and then everything's as normal, or what does a child or an adolescent have to do when they're immunosuppressed and they have a transplant? What's their daily life look like that's different from another kid?
It's a great question. We aspire as a community to try to tailor a regimen that is as much conducive to normal life after transplant as a child who doesn't have a transplant. Having said that, the life looks different for children based on a couple factors. It may look different based on when they had the transplant. For example, the child who had a transplant as a baby and grows up and is doing well, and at the time of entering elementary or middle school is on one or two drugs, it may be such that they have no real impairment on their life whatsoever, and their friends may not even know they've had a transplant unless they choose to share that information. You can contrast this a bit with the adolescent who's been doing well until he develops a disease that requires transplantation in high school, and the impact of the medical regimen that is typically heavier in the first year or two after transplant. So you may start off with taking one or two immunosuppressant medicines, but also a variety of other medications to keep the transplant organ healthy, as well as fight off infection in that early period. And so some patients could take a much larger amount of medicines, antacids, antiviral medication, antibiotics, and their immunosuppressants. And this weans down over time. For each of those two cases, their perception of life quality may be different, and we really work with each of those patients to help them adjust as best as possible. And each of them has different dangers. For the first case I shared, you could imagine that the patient feels so well, has never known not being well, and so really doesn't feel that they've ever had a condition, any significant condition, and might think, why do they really need to take these medications anyway? The one medicine that they take every day, they feel great, and why should they? On the other hand, the other patient may be more acutely aware of the need for that, even though they face the challenges of being well and having a disruption in their life that hopefully will be resolved and get better if they follow this course. So each kind of group has a different challenge, and it really requires a team of the physicians, the social workers, the psychologists to help really explain and educate as best as possible these different challenges that they have. The good news really is that from a outcome point of view, when we do a liver transplant now, we expect that they would have a near lifelong outcome with a 95% survival rate at all comers, and this is really dramatic and has come such a long way from those early failures that happened in the 60s when pediatric liver transplantation was first undertaken by Dr. Starzl.
So what about the microbiome of the patient, and then factors like were they breastfed or not? What was the delivery like? Was it C-section or vaginal? Has anyone looked at how that interacts with the transplant?
Right now, the microbiome is an area of developing interest, particularly for transplants that actually involve the alimentary tract. So the patient who is receiving an intestinal transplant and has the microbiome and gut colonization as part of the actual transplanted organ is quite a challenging transplant to manage and recipient to care for. And the microbiome is a particular in developing interest in those patients. Nutritional factors like breast milk and those type of therapies or history also play into adaptation and recovery of particularly the enteral system, the alimentary tract, and the patient who either gets a portion of their intestine removed as a baby and needs to adapt that intestine. So there's a great adaptive process that the intestine goes through normally after a resection or losing part of the bowel, and it's this adaptation that is speeded by natural means such as breast milk, as compared to more artificial support such as total parenteral nutrition, which is intravenous nutritional support that maintains patients alive but may not impact the ability of the intestine to recover. The microbiome otherwise and nutritional factors through breast milk and such otherwise have not yet been completely well studied, and it's an area of active work right now to see if how from an immune modulatory point of view those type of treatments could boost immunity or at least boost nutritional health better than other methods may.
Okay, well, very good. But what's the near-term future look like? Maybe the next 5 years? Are there innovations that are just about here in the transplant world?
One of the challenges is really trying to balance when we meet with patients who have organ failures to tell them what's around the corner and what should we wait for, what do we need to proceed with now, and what are some of the most likely developments. having been in the field actively for about 25 years, it's been interesting to see what some of those therapies that we said were just around the corner in 1990 are still seemingly just around the corner, to be honest. There's a couple of them that I'd like to mention. The first is gene therapy. Gene therapy has been literally just around the corner for about 20 years now. And there are no proven trials that have demonstrated lifelong benefit with gene therapy, although we were pleased to be part of a gene therapy trial for a single gene defect that leads to a disease called Crigler-Najjar last year. Gene therapy is promising, particularly because half of the children, as I mentioned, may suffer from a genetic condition that if the genetic defect could be replaced, you could avoid transplantation. In essence, we think of liver transplantation or organ transplantation as somatic gene therapy because it delivers the gene product for patients who have genetic defects. And in some of these cases, if you were to look at the organ would be completely normal in the recipient candidate for transplant. The liver looks normal, but it's missing a key enzyme or enzyme pathway, and therefore the toxicity of that pathway affects the brain, the kidney, or the heart, even though they're not in liver failure at all. So the liver transplant functions as gene therapy. I think that there has been progress in the delivery of the gene vector and in the toxicity. So it's been a safe. There are safer ways to deliver gene therapy now than there were 10 years ago, but the efficacy hasn't yet been proven. Probably further down the road is cellular engineering and bioengineering to develop organ subsets or organoids that could replace the function of a liver or a kidney. We're further from real clinical application in terms of intestinal engineering, although I think that with the use of stem cell engineering and iPS cells, which may differentiate into the select organ types of cells that patients need, we may be getting closer. But this right now is still at a very small scale and hasn't been translated into a clinical replacement for transplant. So that is probably further down the road. What we have seen impact for patients who are in organ failure are in some drugs to help with the adaptation of the organ, such as hormonal therapies that have helped intestines to regenerate and avoid transplant. And this has certainly been an area that has improved. We've also made significant improvement in the ability to do support devices for organ failure in children with heart failure. And so the technology for ventricular assist devices and cardiac support, although it has not reached the point of lifelong destination therapy as the final therapy, it has made significant advances in the engineering status to allow patients to have that type of life support while they're waiting for transplant, and in a few cases potentially to be the end goal. Although this is not yet widely available for patients due to the scale needed and problems with clotting over a long period of time. But those are the two areas that I think are from a organ replacement point of view still down the road. From a therapy point of view, in the post-transplant period, the community is working hard at trying to identify tools that could help the immune system to accept transplanted organs better and get to that tolerant state where they don't need to take immunosuppression. Now, this is still also not consistently applicable to patients. We have done therapies like this by giving a combined bone marrow and organ transplant, but the toxicity of this in many cases is not one that is meaningfully applied to children, given the good results that we have with standard immunosuppression. But there are
one quick thing that comes to mind. I guess children would have a lot more stem cells than adults, but is there any possibility of inducing pluripotency in children's cells where it's easier than in adults? Are they somehow more undifferentiatable?
It does seem that the ability for the stimulation of pluripotent cells is theoretically easier to do. Most of the work has been done in adult cases or adult samples, and so this and there hasn't been clinical trials for any solid organ failure yet. You would imagine, we believe that the pediatric recipient would be, for the reasons I mentioned earlier, particularly if you could do it at an early age, would be the most likely to benefit from a successful technology like that, but it hasn't been done yet.
Okay, very good. Well, George, I mean, you're working in a super important field. It's been a really good call. What's the best way for parents or just listeners to find out more if they have a situation they need help in?
I'd be happy to chat with them. They can contact me at CHP Transplant on Twitter or through our email at george.mazariegos@chp.edu. And really happy to chat with parents or families or patients who have questions about this area. And it is one where with our teams and the teams of people working around the country, hopefully we can make a difference for that child with organ failure.
Excellent.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.